Welcome everyone for joining us. So great to see so many people coming in. Good morning, good afternoon, good evening, and good day to many of you coming in today. My name is Rihanna Harris. To those of you I have not crossed paths with, unfortunately, yet, I hope to do so soon. I am the Senior Program Manager here at ICHOM, and I work on the Outcomes Research team. The presentation we're going to be going through today is by the National University Health System based in Singapore. And I am very, very happy to introduce you to our expert speakers, Shika Kumari and Dermot Murphy, both from the National University Health System in Singapore. So welcome. We can't wait to see what you've brought us today.
Thanks very much, Rihanna. We'll go ahead and share. So you're all very welcome to the ICHOM seminar today, or webinar, and we're very happy to share what we have been doing at the National University Hospital through the National University Health System for the past few years. I'm Dermot Murphy. As you might tell or guess, I'm not originally from Singapore. I trained as an orthopedic surgeon in Ireland before moving here 18 years ago, but I've been very much involved with the development and implementation of value-based healthcare projects throughout our own system and also at a national level in Singapore. So Singapore, for those who may not know, we're a small independent nation, about 710 kilometers squared at the southern tip of the Malay Peninsula. And there's about 5.9 million people living on the island, composed of essentially four communities: Chinese, Malay, Indian, and Eurasian. And even though it's a small-sized island, we are divided into three health groups. So essentially over on the east, we have Sing Health. In the central region, we have NHG Health. And on the western part, we have the National University Health System. And we're all under the umbrella auspices of the Ministry of Health in Singapore. So within each of these clusters, we are looking after the primary health care needs of the patients, as well as all the tertiary care that might be required. So within each of our clusters, we would have polyclinics, which would provide primary healthcare facilities, plus lab facilities, radiology facilities, would do screening tests, etc. Then we have family network or networks of GPs that will also be affiliated with our cluster. And then independent GPs that would also be affiliated to us. Within our hospital, then we would have three general hospitals, of which National University Hospital is the academic medical center. We cater for about 1.1 million people in the western part of Singapore. So we have three acute hospitals currently. We're going to have a fourth one built by 2030. Within that, then we also have three national centers, and national centers tend to deal with things like cancer, heart, dentistry. We have two community hospitals, Jurong and Tenga, and we are partnered with a third independent community hospital, St. Luke's. We have 9 polyclinics that are under our auspices as well. And we have the 3 schools of medicine, dentistry, and public health, as well as nursing within our campus. So healthcare in Singapore, okay, from the ministry's point of view, we want it to be affordable for all. And within that, it is not a system that the government pays for everything. All citizens are personally responsible for their own health, and also they must pay something towards their health care. Part of this is offset by the employers and the citizens will part of their salary is used to pay for health services. So it goes into what's called a central provident fund, and that's what they can draw on for their healthcare needs. So this also provides risk pooling. So all citizens, no matter what their health status is, will have these funds safe cared by the government that they can use when they need them for healthcare. Okay. So within the hospital system then as well, the public hospitals, we have the patients that would be suitable for various different subsidies, which are means tested. Some patients would also have employer-sponsored medical benefits. And then from the CPF, you have the MediShield, which is a voluntary health insurance, plus MediSave. And these pay for the majority of healthcare. But all patients must pay something. There's always an out-of-pocket payment, or so some co-payment remains. And this is to try and mitigate the tendency for overconsumption of healthcare. And finally, we have a safety net, which is the MediFund. So after everything else has been used and the patient has paid what they can afford, MediFund then would make up any difference that remains. So Singapore, and why is it getting involved in value-based healthcare? Okay, so we know that around the world that the healthcare costs 7 to 8 trillion per year. Okay, and this is just a diagram showing what $1 trillion would look like if you piled up $100 bills, and in the left corner you will see a figure of a person. So if it's up to the height of a man or a woman, this is how much $1 trillion would look like. Now, healthcare costs 7 to 8 trillion per year, and a third of this is wasted, and it's wasted on inappropriate tests, inappropriate medications, or providing services that are of little value to patients, and duplication of tests and services as well. So across the world, we know that the healthcare costs are rising, and Singapore is no different. The costs are mainly due to new medications and new services, including new technology. Singapore is renowned for its health service. It's one of the top 10 countries for longevity for its population. And when we look at the healthcare expenditure per capita versus life expectancy, you can see that Singapore, though it spends relatively less than many other developed nations, its life expectancy is still very high, secondary to, I think it's Japan. And then within that, we've seen when we can look at our life expectancy versus the health-adjusted life expectancy, that Singapore is also doing much better than would be expected. However, within that, over the past 10 years, we've seen an increase in obesity, high cholesterol, blood pressure, and diabetes has been roughly the same. But we're expecting a massive increase in some chronic diseases. So 1 in 7 adults will be expected to have diabetes by 2030. So this is increased of 1/3. And 1 in 220 residents are expected to have a heart attack, which is up 60%. 180 will have cancer, up 70%. And 1 in 230 residents to have a stroke, up 110%. So not only are we seeing an increase in these chronic diseases, but this also means that they have chronic disability, which has an adverse effect, not just on the patient, but also on the population, because we see families, members stopping work in order to care for their loved one after they have been treated initially for these conditions. Also, Singapore's population is decreasing. So this is a graph showing from 1960 to 2016, showing the total fertility rate in Singapore. The gray line there is there was a policy of no more than 2 children. But even at that time, you could see that Singapore's population was decreased. And even in the recent past, we see that it continues to decrease. And currently, we were at the lowest level ever in 2024, but you can see that there's 0.97 births per women in Singapore currently. Our population is getting older. So in 2018, we have now more population over the age of 65 than we have under the age of 15. And we're dependent, as you've seen from earlier on our working population to pay into the funds that will eventually pay for healthcare. So with a decreasing population, there will be a subsequent decrease in funding that may be available. So the working population per person over the age of 65 has been up to 2021 is about 4. But we're projecting that by 2025, it'll be 2.6, and by 2050, it'll be 1.5. Our healthcare expenditure is increasing. This is looking at in relation to our neighbours, but you can see that there's been an exponential rise in our healthcare expenditure since 2004, and this is reflected when we're looking at the compound annual growth rate for the national health expenditure and also for the general health expenditure. So when we're looking at the general health expenditure, it's essentially looking at what the government is paying towards health in the public health or in the public health institutions. And for the national health expenditure would also be including private healthcare. But you can see that it's been increasing dramatically. And from 2010 to 2020, we saw nearly a doubling of the healthcare costs. And it was projected by 2030 that this would be tripled. And this is not sustainable. So it's from this point of view that Singapore started developing plans for how to mitigate against this decrease in population, increase in costs, and how to maintain our status as a high quality healthcare nation with a reduction in financing for this system of care. So by failing to prepare, you're preparing to fail. And we've been preparing for this for the past 10, 15 years. So even 10 years ago with the initial government paper on healthcare, which was called the 3 Beyonds. It had many value-based healthcare principles. And then the most recent paper, which is called Healthier SG, further expands upon those foundations. So our hospital was looking for solutions to this as well, as were all the members of the various different clusters in Singapore. And about 2005, our leadership came across the Porter and Teesburg's book, Redefining Healthcare, but they hadn't been able to see this put in practice. And they were looking around to see how best this might be introduced as a program. Most of the hospitals in Singapore have done Kaizen, they've done Sigma 6, they have done Toyota Lean. And while all those systems were very good at improving efficiency, it still lacked in showing improvements in clinical care or benefits to the patient by having these systems in place. Whereas Porter and Teesburg were advocating looking at quality from a patient point of view. So with this in mind, our senior management had heard that Utah had instituted such a system in 2015. And they were kindly invited over by Dr. Vivian Lee, who was the president of the University of Utah Healthcare at that time. and she kindly shared with them what they had put in practice in Utah. So there was a lot of sharing. The team from Utah actually came over to us then within a year or two. So when we came back to Singapore, we based our framework on how to improve quality and sustain costs on what Vivian Lee had described in her JAMA paper from 2016, which is an implementation of value-driven outcomes program. So it was based on that, but it wasn't exactly the shoehorned into position. We modified it to suit the Singaporean system. I'm going to pass you over to Shika Kumari, who is the director of our value team at NUHS, and she will take you through the methodology we adopted for this system.
Thank you, Dr. Dermot. So we had our eureka moment during the visit. So we knew that what needs to be done, but what we did not know that how do we do that? So we started with our literature review and did some of the readings, went back to the JAMA paper, read this Potter's paper, and started finding that what should be our first step, or what should we prioritize in order to get to the point where we were able to implement the value equation. So however, Potter had this 6 priorities or 6 things to be implemented to be able to fix the healthcare or implement the value-based healthcare. We agreed in our local context, the very first thing we wanted to do is to be able to measure the outcomes for the patient and cost. So we were very sure that if we were to implement this kind of framework, then we need to have a system, or we need to have a platform to be able to measure the outcome and cost at every episode or every patient. So to be able to do that, we needed a proper technology platform as well as the data architecture. So there are a few things in this methodology. What I'm going to explain is how we went about implementing that from scratch without having any precedence. So we started with this. We clearly outlined our challenge. There are few aspects of value-based healthcare, but the very first thing we wanted to deal or tackle is to be able to measure the outcome, and for every dollar we spent in the treatment. And then the second part is that how to improve that. Is it good enough, or is there any room for improvement? So with that challenge, what we came up with is this little framework to do our projects one by one. So the very first thing what we did is we knew that this kind of model will work in a homogeneous patient cohort. And this is what we had learned from Utah when they had shared. So our starting point was to target a specific condition, which is quite homogeneous in nature, and then define the quality measures. So defining quality measure is about identifying or defining the gold standard for that patient cohort. So with that, we have a target population. We knew that what we wanted to measure or what we wanted to deliver for that patient cohort. So the third part was that, okay, how do we really operationalize that? So we noted when we were defining the quality measures that it doesn't really only account for the clinical data. So when we were trying to fit that or identify the measures, then we realized that, oh, wait a minute, we need to have a system or a data architecture to be able to join clinical, administrative, and financial data to be able to complete this value framework. So as we know that the value framework has a quality component and the cost component. So that's what we did it. We developed our in-house system and platform to connect these 3 or few types of data to be able to complete or visualize or able to identify the kind of quality we were providing for that patient cohort. With that, when we had that idea, then we almost knew that by year on year or with variation analysis that where is the waste or where is the area of improvement. And that's where we went back, looked at the cost and health outcome optimization, and then it was a continuous feedback loop. So this is what we had developed, and we are still working on this, but there are a few developments which we will share in next few slides. So with this as a starting point, so whatever we had an idea that this is what we are going to do, the starting blues were real. How do we get it? Do we need to really set up a full-fledged department before we initiate this improvement, or we should test it with whatever existing resources we had? And we knew that we are embarking on a value project, so we couldn't have asked for moons and everything before we really show the value. So what we did that our senior management kind of discussed with few of the coalition of willings, what we call, and what our initial senior leaders said, and came up with this 2 days of workshop. One of the things we also realized that this cannot be driven by the one kind of team. It is not a only clinicians project. It's definitely not informatics project, and it's not the QI and not the finance. But one thing we also agreed that all these 4 groups of department or people needs to come together to be able to set up this. So we got a few clinicians, informatics people to do the data work and the quality improvement, to have this eye of identifying the areas of improvement, and most importantly, our finance colleague. So one of the things which NUHS is very proud and we have done right is that having the quality and finance as a co-sponsor for this kind of project. So this is something, one of the good thing we had done, and we are very proud of it. With that 2 days of workshop, we saw that it is achievable and this can be done. And that's when our senior management said that, okay, why don't we invest and do, on this kind of thing? This can be done and implemented in our local context. But the question came that how do we go pick the conditions? So during the coalition of willing and the pilot stage, we had kind of learned or chose the 2 conditions which Utah had shown to us. So one was a surgical condition, total knee replacement, and second was pneumonia, community-acquired pneumonia, and that's something we tested on. But we knew that we need to have our own selection, or we need to have our own prioritization framework. So there were few ways we could have done, but from informatics and data-driven, what we did that we kind of fell back on the same JAMA paper where they had used this coefficient of variation and ultimately computing the opportunity index. So the coefficient of variation is the concept where we said that for a particular homogeneous patient cohort, what is the standard deviation of cost, and divide by the average cost. So what does it mean that the CV is measure of variability and was calculated for every condition? And what does it mean that if you have higher coefficient of variation, there are higher chance of optimization, and there are high chance of getting the maximum value of the effort? And this was the kind of thing we implemented in our data. So with that, we selected some of the project, and then we went to our senior management and clinician champions and embarked on that. So that was one way of doing it. There were 2 other methods of how we selected our project. One was the bottom up. So we ran a call for projects. So we blasted an email saying, oh, we are doing this value project. If you're interested and you see that there are a condition which can fit or which are suitable for this kind of framework, please fill this form. And that was another way we selected some of the project from ground up. The third was the strategic projects like Peak of Excellence and things which we thought that we want to excel in as our strategic priority. And hence, this kind of measuring and monitoring framework will be must have. So there were these three ways which helped us to select the initial projects. When we selected the initial projects, then the whole idea was to how do we define the quality, or how do we complete the value equation and the Q part of it. So we discussed this internally, and we had few subject matter expert coming in and deciding, but we agreed for these 4 key pillars for our quality dimension. The first was basically the SEER hygiene factor, and we called it as a clinical quality and safety. So this must not go wrong. So those are the things fell under the clinical quality and safety. The second was appropriate care, and these are some of the process outcomes. So the hygiene factor is that clinical outcome, and you would want to, if you treat that patient for that patient cohort, then you want that outcome to achieve, and you're treating for that outcome. The second is what are the SOPs and what are the appropriate care you are doing to achieve the outcome. So we did include some of those indicators. The third was patient-reported outcome, if we have available, and we will touch base on this a little bit more. And fourth was patient experience. So these were the 4 dimension we kind of agreed, and every time we embarked on any new projects, we came up with this 4 dimension and asked clinician champions and subject matter to think from these 4 dimensions when we are defining the quality for that particular condition. So clinical quality and safety, things like readmission, unscheduled return to OT, complications, mortality, length of stay, these were under the clinical quality and safety. Appropriate care, the things you want to do, DVT to be done within certain time. You would want chest X-ray to be done within certain time, antibiotic givens, surgery done, rehab done within certain time. So these are the process measures, and we did include that in our quality, saying this is somehow related to the better outcome patient is going to get from the treatment. The third is patient-reported outcome, which is, again, not all the conditions were collecting this regularly, but things like mostly orthopedics condition had existing patient-reported outcome, and we kind of merged this with in our data framework and able to do the value equation. Fourth is patient experience. So NUHS has this patient experience survey sent to every patient who are treated within our institution and discharged. So, however, the response rate is not very good, but we did include that in our quality equation. So this is how we took care of the Q part of the value framework. One more thing we wanted to discuss or share with you is that we were very clear that we wanted to adopt all or none method. And this was another paper we had read from Geisinger, and kind of we agreed that when we are treating any patient in that particular cohort and the list of quality indicator is agreed upon for that particular patient, then there is only one way we can say we have provided the gold standard to the patient, whether if we have met all the selected indicators. Having said that, we do agree that there are various reasons why that patient has not met a particular indicator. And we never said that the CQI, which we call it clinical quality index, should be more than 80% or 100% for that condition. But the whole idea was to able to calculate the clinical quality index based on the number of patients who has met all the clinical quality indicator set for that particular condition. So we agreed and we are living with it. In our communication to clinician champions ground, we do explain it in 2 ways. One is that clinical quality index, another is that indicator compliance. So there is a way we can still see the individual indicator compliance where you see, okay, for overall this patient cohort or the readmission is 20% or planned return is 20%. So there are few ways of cutting this data, but yes, we did agree and implemented all or none method for the CQI, Clinical Quality Index. We did go back with ICHOM. We have been following and working with ICHOM for some time now. So when ICHOM SITs came, we kind of aligned. We had our quality indicator database, and we kind of overly or aligned. And we thought that we saw that our indicators were quite aligned with what NEJM had put it. So for NEJM had these three category: acute complication of treatment, which kind of appeared as a hygiene and our clinical quality and safety. Disease control were some of the things which we had put it as a process indicator. And the patient-reported health status is some of the instruments we were, or division or department we're currently using. So this kind of gave us an assurance that we are already there, and we are not, we are not missing out. One of the things which is not like we are getting onto it and we are not there yet is the patient-reported outcome measures. So when we started back in 2016, 2017, we just wanted the value equation up. And we wanted, before that, we didn't have a method to put clinical quality and clinical quality and the cost together. So we were busy in doing that. However, we were always cognizant of the fact that the patient-reported outcome measurements were lacking and it was fragmented. So in last 2 years, we are putting our most effort in unifying this and coming up with a prompts strategy and getting this bit of the data back in the value equation. So our cluster has started this e-prompts strategy, and we are implementing this for system-wide within all the hospitals in our cluster. So this is where one of the areas which we are scaling, and in next 1 or 2 years, we will be putting our effort into. This is something I'm sure you might be kind of interested in looking for it, that how did we develop the architecture? And so this is totally in-house architecture. What we did, that we identify all the system which was collecting on the clinical or operational or finance data. Having said that, that means your EMR, whatever EMRs you're using, your lab system, your radiology system, your OT system, operating system, all the system, your medication way of collecting, ordering system, and putting all the data together, stitching them to make sure that we have one patient, one record. And we did that. We did that in our video framework, where we were able to do the processing, and with help of, we have a very strong data engineering team. With them, we kind of developed one patient, one record view. And at the end, we used visualization software. Like, we had few licenses of Tableau, and Tableau did the job. So we just stood with it and did the visualization of value equation using Tableau to be shared with our clinician champion. So all this work was done behind, and what clinicians saw is their compliance and reports, which I will share in our next few slides. These are some of the tools, nothing fancy, very basic, and we had it. By then, we already had Epic, and we were able to get the data from Epic, and we had a SAP for financial. We were able to get the data. We used Visual C# SQL Server to do our data cleaning, extract, transform, load, and for visualization, we stayed with Tableau, more from the server point of view. So these are some of the very basic tool, which still we are working on. We have a different, we are upgrading with new technology, cloud, and other ways. But as of now, this system is quite working well for us. The third point, which we are very proud of to be implementing right, is able to do the cost accounting. So when we started this project, the finance came as a co-sponsor, and they spent effort together with the clinical side and the administrative side to work on the entire costing methodology. So and this costing methodology is totally aligned with our national costing guidelines, which is more localized or more in Singapore context. But we were able to develop our costing methodology to able to account all the manpower, drugs, supplies, consumable, anything which was consumed or incurred or used during that treatment. and we were able to then. But the basic is that anything we use, what is the unit cost and what is the utilization, to able to see that the kind of cost we are incurring. And to identify the areas of improvement, we followed or changes the year on year, saying, oh, is it my room utilization is going up for the same patient, or is my drugs or consumables are varies between two different surgeons or doctors. So these were some of the analysis we were able to do it. We did implement time-driven activity-based costing where applicable. So things like consumable, medication, we just use it, the utilization and unit cost method, but things like how long and what is the surgeon time to do that operation was done using time-driven activity-based costing. How long the surgeon was in OT, how long the anesthetists were there, what were the cost of anesthesis per minute, and we calculated how long was the procedure, multiplied with it to come up with the cost of surgery for that patient. And then we added the medication, consumable, all the other costs is what incurred during that episode of treatment for that patient. So we were able to we were able to do that. This kind of analysis also helped our finance colleague to see that what is the costing trend and all that. So these are some of the things they say that, oh, how my unit cost is growing, and is it growing more than the inflation, and what are the areas of no or low value care, why we are doing this. Some of the contracting issue we identified that, oh, why were you so why are we contracting the entire box of implant while for that surgery we are just using a part of it. So there were many things came up just by seeing the data and analyzing it. So those were some of the optimization we did along the way. So this is what we had. We had a quality data, we had cost data, and patient-reported outcome where possible, and we were able to stitch that to see that the kind of quality and cost we are incurring for that cohort. But how did we share and what did we report it out to the right stakeholders? So we had few different types of reports. So at the senior management, we did that the project trajectory, what we said. So one dot here is a one project, and we see how it is moving year on year. This could be also charted month on month, but sometimes the month on month is lots of noise and it may not be very meaningful. But at the steering committee level, at the CEO of the hospital level, they would want to see year on year changes in the trajectory. So if you see this graph has two axes. One is the quality axis, the other is the cost axis. And most of the like projects, we would want them to be in the upper right corner where they have improved quality and kind of rationalized cost over the year. But this kind of charts gave senior management to able to see which direction are we heading, and is there anything we can learn from each other, because we have few three general hospital within our cluster. Then we did this monthly video report where we got into the detailed month by month list of all quality indicators. So this colorful little lines in the down part of this graph are the individual quality indicator, and these blue bars are the caseload. So this kind of chart were suitable for head of department and the clinician champion level, which even the bird's eye view, they could see that, oh, whether the trends are right or not. And if they implemented any intervention, let's say during March of that year, how my data is working and seeing whether that implementation initiative is effective or not. So we did this kind of chart for head of department and clinician champion on project team, more on the ground level. We also proudly implemented the individual doctor report, which we shared with the HODs and the doctor themselves to see that how are they doing and what kind of quality they are achieving for the projects treated. And we did share the individual clinician report with respect to department mean. But mostly we are working with here where you could see all your colleagues side by side, and you could see that how you are doing with compared to all your colleagues within the same department for that same condition. We have a method to stratify the cases by Charlson Comorbidity Index, frailty, and there are many other ASA. There are a few ways of cutting and things, and year on year. Depends on how deep we want and what are the queries and questions we receive in the ground. We have the ability and the granularity of the data to incorporate that. So with that, I will like to pass this again back to Dr. Murphy to take you through a proper case study that how actually it looks like when we did all this.
Thanks very much, Shika. So we're just going to look at how we implemented it for one of our projects, which is total knee replacement, and how we have revamped that since we first started doing it back in 2016, 2017. So you would all know the value equation already. These were the clinical indicators that we had chosen for this particular project. So you can see on the left-hand side, we wanted no emergency readmission, no unplanned return to OT, length of stay less than 5 days, administration of VTE prophylaxis, no blood transfusion, no inpatient mortality, and no postoperative complications. And these had been chosen by the clinician champions in cooperation with their departments. And you can see that there's an uncanny resemblance to the ICHOM indicators as well, but these were independent of ICHOM when they were chosen. You can also see that we were using the SF36 and the Knee Society score, and we also had the Oxford knee score as well. And then we had a patient experience score. Now, the patient experience score essentially was any patient who had a knee replacement after they left the hospital within 24 hours, they would get an SMS asking them whether they felt that essentially it was a satisfaction questionnaire asking them whether the staff had been nice to them, did they feel listened to and cared for appropriately. The demographic for our groups, our patients once we had established the value-driven outcome framework, we initially established a baseline. So that was looking at what was happening to the patients. And then from that data, we would look at certain areas that we wanted to improve. And then we would follow the data going forward. So our pre-implementation of value-driven outcome framework for total knee, our patients were a little bit younger and a little bit healthier. And this was probably in line with the Singaporean demographic, which shows our patients are getting older and a little bit frailer. Okay. Our initial data showed that our patients were staying for a long time post-op in hospital, more than 5 days. Now, most units in developed nations would have a very quick discharge for these patients. And in the US, they would probably go home same day or at least next day for rehab, etc., closer to their community or in their community. But in Singapore, there was you might say, tradition of prolonged stay, and patients sort of felt that when they came in, they would need to stay for at least a week before they would go home. And then when they would be due to be discharged, there may be family reasons that they would be unable to do so. The family would have gone on holiday because they expected that their loved one would be staying for a prolonged period of time within the hospital. So we saw that one of the things that we needed to do was have improved education for our patients. And we did that by having a joint school. So anybody who was undergoing a arthroplasty surgery would be brought to the joint school along with a loved one, and it would be explained what to expect, including that they should be home within 2 to 3 days. And if they required further rehabilitation rather than on an outpatient basis, then they would be going to a community hospital within the same period of time. They were also taught that they would be expected to be up and walking either directly after the operation or within 24 hours of the operation, just depending on what time of the day the surgery took place. Okay. And by changing the perspective or the expectation of the patients, we changed the conversation from, oh, I didn't think I was going home, to why am I not going home within 2 or 3 days? Why am I staying in hospital? Which was ideal. The second thing that we saw was that our blood transfusion rates were too high. Okay. One of the major reasons for our blood transfusion rates being high was that our patients were anemic preoperatively. They were coming in with low HB. So we were able to guide our patients from before having surgery, that when they were assessed 2 to 3 weeks, or sorry, about 3 to 4 weeks before their surgery, that they would then be enrolled in an anemia clinic, which was run by the hematologist, and would be treated appropriately. So by the time they came in for their surgery, we weren't concerned as regards low HB. The third thing that we saw was that our rates of DVT prophylaxis were relatively low, as in that it was about 80-something%, and we would expect it to be 99 to 100%. The reasons for this also, we generally in Singapore, we're using mechanical prophylaxis rather than chemical prophylaxis. Our patients are not in a single unit, so they may be on different wards throughout the hospital, and the nurses on those wards may not be fully au fait with the orthopedic post-operative regimes. And also, we found that even within the orthopedic wards, there was a decrease in our expected DVT prophylaxis. But when that was investigated, it was found that the patients were actually getting calf pumps, but they weren't being charged for them. So it was a combination of decreased awareness, and also both of application of the garments required for a calf pump, but also the charging of the patients for those. So on implementing this with a series of re-education for the patients as regards expectations, the joint school, the anemia clinic, and re-educating and informing the nursing staff on all the wards that orthopedic patients may go to. We found that we had improved the length of stay, and that the percentage of patients staying over 5 days dropped from 31% to 9.31% by 2021. Blood transfusion also dropped. So from a high, you might say, of nearly 15% in 2015, dropped down to 3.19%. And then the DVT prophylaxis improved from 89% to 92%, and then further went up to about 98%, which sort of remains at currently. When we look at the CQI is Clinical Quality Index, and this is calculated by looking at all the clinical indicators. And as I said, we have an all or none methodology. So if a patient has hit all of those clinical indicators, they pass. They get 100% CQI. But if a patient fails any one of those indicators, we get a 0 for that patient. And this is not done in a punitive way to try and whack the surgeons, but it really allows us to see where we are failing the patients, where the quality can be most improved, or where we should focus our attentions on improving the quality. But you can see that when we started this in 2015, that our CQI is relatively low at 50%, and we're able to bring it up to 80% within the 5-year period. And then our costs also had reduced over the same period of time. Okay, so we have a 10% of cost avoidance to hospital over the 5 years, which translates in US dollars to 2.2 million. From the patient-reported outcomes, we had been collecting patient-reported outcomes in orthopedics for a number of years, and they resided in Red Cap system, so which was a separate system to our NGMR. But when we did the analysis of it, we could see that the patients from the PROMS records, that even though the patients were going home earlier, that the patient-reported outcomes were significantly better on a number of items, both in the SF-36 and in the NEJM Society scores. And our patient experience also remained very, very good. As in, you can see that the response rates improved, and Singaporeans, if something is wrong, they will tell you it's wrong. So we take it the fact that we're only getting in 10% response rate, that the other 90% were happy, and of the 10%, the vast majority also gave high scores for the service that they were receiving. Continuing on from that, then, in the past nearly 8 months, we still wanted to reduce our length of stay, and we wanted to do so in as safe a way as possible and maintain the quality of care for the patients. So we saw that there was still nearly 3 going on 4-day length of stay for patients, and we want to reduce that right back. So we did the analysis, doing a fishbone analysis, looking at the staff and the patient's environment and system, and there's multiple different areas that we saw that could be improved, but a lot of it was process related. So from this, then we had a new project, which was the Focus Accelerated Surgical Treatment for Total Knee Replacement, FAST TKR, where we were improving our ERAS protocols for total knee replacement. And this involved, again, education and training, both of the new house officers that will be joining us every 3 months, also cooperating with our hospital at home services. So patients that would normally have stayed in hospital for longer now could go home, because the hospital home would be taking over their care in the home. We had regular audits and presentations of those audits to the arthroplasty surgeons, and again, repeated communications to all levels within the arthroplasty unit, across the whole clinical team, including our partners in the community hospitals and the NUHS at home, to improve the length of stay for patients. Things like ensuring that protocols were followed as regards post-operative pain relief, post-operative preparation of documents for patients to go home or go to community hospitals. All that were enhanced further. And again, the patients were also educated in advance of the operation that they could expect to be up and walking the same day of operation, and also that they should be expected to go home the day after the operation. And they were made aware that they may be requiring the hospital home services when they went home. The results of this have shown that we've managed to decrease the length of stay by another day, which equates to about $700 per day. Okay, but the important part is that our CQI, or our quality, has not diminished over that period of time. So you can see that the cost difference is down by $637 per patient, but our CQI remains roughly the same as it was before. And overall, we would see a cost saving to the hospital of about $400,000 for the arthroplasty unit. Okay. When we look at the current PROMs as well, and comparing it to the previous PROMs, looking at the Oxford Knee Score, the Knee Society score, both the function and the knee score, you can see that this accelerated discharge from the hospital has not been of any disadvantage to the patients, that the patients themselves have not suffered as a result of that. And our readmission rate is very low. and it hasn't affected the other indicators such as blood transfusion or any surgical complications. So by utilizing this, utilizing our VDO framework, we were able to increase the number of patients discharged without compromising the quality of care. Okay, and this frees up resources, but also will allow the hospital to admit more patients for treatment. So that's an example of how we have used our framework to improve. Essentially, we pull the data, analyze the data, and then we feed this back to the clinicians so they can make changes to their clinical pathways. And then we can monitor what effect those changes in the clinical pathways are having on the patient journey. So it's, as you might say, a continuous learning loop that's established for the clinicians. And they get both clinical and financial data, which is something that they never had previously in their career. I'll pass over to Shika to talk about the challenges and what we've done to improve.
It sounds quite interesting, but it didn't happen without the challenges and some of the solution we had to put in to tackle them. So there were three key challenges, and we had kind of sorted them as they come, and there are different methodology to do it. The very first challenge we had is the buy-in. This was a new thing. So the buy-in from the clinician was the key, and identifying the like-minded, invested into the enthusiastic clinician champion was the key. So you wanted the kind of the catalyst kind of clinician champion who takes it, owns it, and goes back in the department and discusses with HODs and implements it. So that was one of the initial thing. We had to gain trust. We had to build relationship and share this and make them believe that this is not punitive. This is really for the quality improvement. And another thing was support of senior management, because we have, there are types of senior management, some has support, some has not, but we were quite fortunate to have our support from our senior management whenever we required. The third was accuracy of data, because it's very first thing, any data you show it to your clinician champions or to any HODs or senior management, the very first thing they will come saying, doesn't look right or is funny. Can I see it? So our framework was robust enough to be able to give them the individual patient case level details when we said that, oh, there was a post-op complication. So the first couple of years or couple of months, we were being tested on that. So having a right data framework and having the accurate data is the key. Because once you lose the trust, then you have to rebuild it is a big task. So we were very cognizant of that. Whatever we worked, we were very we were aware that we need to have our data correct before we show it to the clinician champion and comment on it. The second is data and IT infrastructure and ever-growing types of data. So when we started, our normal hygiene, quality, safety, and appropriate care or process indicator were good enough. But as we built it, then the demand came that, oh, can we have social determinants of health? Can we have their affluency, saying that whether if the patient didn't comply to medication, that what was the type or what was the scenario. So these things came as long as when we grew up, and these are happy problem, but we are still trying to see what are the other kind of data we can bring back in our data framework to make our value equation robust and make more meaningful and even more robust analysis. Second one is patient-reported outcome, which we shared that our NUHS is committed to it, and we have already started our journey with it. And the third and very important is the computational power and the increasing volume of health data. So by now we are talking about 8-9 years of data. So it's going to go up because we are doing the data year on year, and we would want to look at the trending. So we do have the data and computation power. These are some of the things. The third one, which is not second, the third one is value-based healthcare culture. So how do we incentivize and come up with or implement rewards framework for the teams or for the departments or clinician champions who have taken on this or who are endorsing this. So that's something we are also working together with our leaders, senior management and finance and HR colleagues. This is very important thing, and I wanted Dr. Murphy to do it, but I will take a chance to do this, that we do celebrate success, and we always kind of go to the conferences and showcase our good work, what we have done through publications, through posters, abstracts, and even the talks and all that. So we are very serious about celebrating success, sharing the good work our hospital or our organization is doing. Where are we now in our journey? In all the case study and all, you just saw the first dot, which was TKR, very a single episode within a department and very homogeneous patient cohort. But we have grown from since then. We have taken care of multiple episodes within a hospital, like so breast cancer, which requires not only the surgery, if not surgery, hemo, chemo, red, onco. So we have done those kind of project, connected the data across the setting. We have done hip fracture, which is acute plus community hospital. We have done primary care, diabetes and lipidemia and hypertension. And finally, we are moving into the end-to-end projects like DM, from primary until the complications and end of life. Similarly, CKD, we are also doing some of the service line project, which is not really the patient cohort homogeneous, but more at the service line, like NUHS at home or our home care service. As of now, we have 59 unique conditions, across all the things. This is the list of our conditions we have implemented, 59 unique conditions across the setting, primary care, secondary, tertiary, and some of the service line project. And I would like to hand this back to Dr. Murphy to share the way forward.
Oh yeah, so we've been advancing all the time and trying to, and we have been able to advance value-based healthcare across our cluster. So have a culture developed within it that we're looking at how to improve the quality and cost. So coupled with that, then we have the ministry who has now introduced this appropriate and value-based care, which is a combination of reducing unnecessary duplications, unnecessary medications for patients, unnecessary tests, etc., and introducing that as part of the framework for all the hospitals across Singapore. Within NUHS as well, we have also been looking at including carbon as part of the value equation and the carbon costs. So such as when we're looking at meter dose inhalers for treatment of asthma and similar conditions, very high greenhouse gases as a propellant, and changing this to dry powder inhalers, which, though they are more costly, are environmentally more friendly. The same as regards getting rid or reducing the use of high greenhouse gas, anesthetic gases, etc. And going forward, we'll be looking at our water usage, electricity usage, etc. Within the institution. Finally, I'd just like to thank my team. So the NUHS team, the value team, is made up of all the people you see in this photograph, plus we now have 2 new people that unfortunately we haven't included yet. But there's about 10 to 11 people. Most of half the team were repurposed from other jobs within the hospital, and the other half have been slowly joining us as we expanded our projects over the past 8 years. So with that, I will pass it back to Rihanna and the ICHOM team, and we're open for questions. Thank you.
Thank you so much, Dema and Shika. We have a very, very engaged group of people with us today and some incredible questions that are coming in. So without further ado, I think we should jump right into them. The first one we've got here is, what is the distribution of health financing from the various sources mentioned, government, employer, contributions, and insurance, etc.?
Okay, so speaking from the public health institutions, the vast majority of the costs are based on either government subsidies or the patient's own CPF funds, which is MediSave, MediShield. Okay, so that would make up the vast bulk of it. But the patients can expect to pay somewhere in the region of 30% out-of-pocket expenses themselves.
Incredible, thank you. The second one we've got here is somebody would like to find out how the outcomes and cost components were mapped to the granularity of a patient's encounter. Does the system capture the costs for clinical manpower time, facilities used, etc., and it evaluates this against the clinical outcomes that arose from the episodes of care?
Yes, I think Shika had mentioned that in her slides as well, that for the costs, we do costs in a combined way. So we look at the utilization costs per patient. So all these are done per patient, not per condition. And then we amalgamate the costs for all the patients that were treated for that condition to give us our overall cost. But part of it is the utilization of services and of drugs and of tests, which would have a cost per each item or each service item that they use. And the other part then is the costs of using the theatre. So if you have a senior consultant operating versus a what we would call a senior registrar or associate consultant, the costs are different, or what the hospital charges for each of those is different. But that is all computed as part of the time-directed activity-based costing. So we would know what the cost of a certain surgeon for a certain period of time doing a certain operation with this implant, with this particular coding for the operation, what that cost is to the patient. And that is used on an individual patient level as well.
Amazing. And in addition to that question, the same person was curious of whether the data was real time, integrated within the systems, or retrospective.
So our data is about, we run about 3 months behind time. Okay. And the reason why we do that is some of our clinical indicators, even though our data is refreshed every month, that our clinical indicators sometimes take about 2 or 3 months, because we're not only looking at patients being readmitted within 30 days, but we also look at 90 days and things like that. So from our own purposes, it suits us to relook every 3 months. So we're currently looking at the data from May. So yeah.
Fantastic. Another question here we have is, are the CME hours available for Numerous Plus?
Sorry again?
Are the CME hours available for Numerous Plus?
Well, CME, continuous medical education for points for what?
We've got the word here, MUAMARIS plus.
Whether they can use this webinar as for their CME hours? Is this from?
This might be somebody looking for CME points for education purposes in maybe Singapore or elsewhere. I'm not quite sure whether it's actually to do with this, but if they can clarify, it might be good. I think they're talking about, can they claim it for part of their educational reasons? Okay.
I see. We'll circle back if that one's clarified. Moving on to the next one, we've got, would you have expected the CQI to have increased over the implementation period?
So yes, we do actually expect it. And the reason being is that we know from literature that when you tell somebody that you are monitoring what they do, they get better. Okay. It's just human nature. If you know what that people are measuring what you're up to, they will tend to do better or get better. The second part of it is because we are feeding and we're sending the data directly back to the clinicians on the ground, and we send it back. We tell them, you are Dr. X, and they'll have A, B, C, D, E, other doctors, and they can see the data for all the doctors that are treating that particular condition, but they'll be only told who they are. And they can look at that for all the clinical indicators. So this is the report we send. And that forms a bit like peer pressure, that they can see, oh, so that she's doing better than I am. Why are her patients going home before my patients go home? What is she doing? And we notice that after we send those reports, that there's also an increase in CQI, because they realize, oh, well, maybe I don't need to keep the patient in for an extra day. They can go home quite safely because everyone else is sending their patients home quite safely a day earlier. Okay.
Fantastic. We have someone here curious about what your PROM's overall response rate was.
So, okay, the PROMs for knees is very good. Okay. Our overall PROMs is
40%.
which
40% with the change in the.
So there's the way the PROMs is the way the PROMs is collected is initially they will be given SMS or WhatsApp, or they electronically be asked to fill in the PROMs, and then they get a reminder, okay, and then they get a phone call, okay, and then when they come to the clinic, we have people that will also do their ensure that the PROMs are done. So we have got a response rate. So just from the initial SMS, it's about 40%. With the reminders, we can push it up to 60%. And then with the clinic on board, they can get it up to about 80%. Okay. The PROMs, we have been doing PROMs throughout the cluster, yeah, for a long time, but it's been fragmented. So we'd have them, some of them being done in NUH, and then some would be done in our sister hospitals in Alexandra or in Enteng Phong, so that they're the 3 hospitals within our cluster. So what we're planning on doing now is having a unified, homogeneous system of PROMs collection throughout the cluster. So everyone will be getting general health questionnaires, and they will for specific questionnaires and for specific conditions.
Amazing. Thank you so much for answering that one. We have another one here that says, could you please share what is and what is not scalable to other patient groups as generic building blocks throughout your health system?
Okay, I'll have to think about that one. Okay, so what is scalable and what is not scalable?
Yes.
Okay. So
while you think
that,
so scalable was that when this framework was implemented, it was proven or written up that it is only applicable for homogeneous patient cohort. But we tested it for projects as a service line project, we call it. This is our local terminology. What it meant was that even for a particular center or particular concept or a program, you can use this value framework. And this value framework doesn't need to be linked to a very homogeneous, but the kind of indicators you're choosing will be different. But you could still use this framework. So that's something we saw that it is quite scalable. The things which is not scalable is that, again, going back and using the same 4-dimension of quality indicator for all non-homogeneous group. So for example, when we said that we had an end-to-end project, so every treatment and every touch point or treatment block needed to be a different set of indicator. If the breast cancer patient has gone for surgery, then this indicator will come in the picture. But if patient did not go for surgery, directly went for the other conservative or the aggressive treatment, then the other set of indicator will come. So those were some little tweaks had to be done. But if you say that based on our experience, we saw this value framework can be quite generalized, not only in this homogeneous patient cohort and thing, it could be quite generalized. It depends on how you are, implementing it and making sense out of it.
Yeah, so it's very scalable for elective surgery. Okay, super scalable. It is scalable, but it's more difficult when you get into complex medical conditions. But we have, yeah, when you have comorbidities. But we're trying to account for those through segmentation, stratifications of the patient cohort. But it is a bit more difficult doing that. The other way that it's difficult to make it scalable is if the data is not available. So we're fortunate that in Singapore, okay, we've gone from having individual sort of NGMR electronic medical records to 2/3 of the island is now using a single system of electronic and medical records. And within the next 3 years or so, the whole island will be on a single system. Okay, so again, this will means that the amount of data that we can actually collect through this system is much better than what we could do before. So when you had people like the ophthalmologists, say, following cataract surgery, previously we had great difficulty trying to, because we don't go through the case notes on an individual basis. We need to pull this data automatically or automate the collection of data, that if you wanted to look at what their visual acuity was pre and post, that was difficult to do. But we can do it now because our system allows us to do it now. So we have seen, depending on the type of system that you're using for NGMR, that the amount of data that you can get and the quality of the data that you may be able to pull is dependent sometimes on how that data is inputted in the first place into that system.
Fantastic. Thank you. This might be our last question just due to time. But could you provide some more detail about the incentive programs used to improve performance, especially for clinicians?
Okay, so this is a work in progress. There have been two occasions whereby clinicians have got a very moderate amount, as in I'm talking about $100 or $200, what we call in Singapore an ang pao, a red packet. So it's traditional that say Chinese New Year, that unmarried people would get a red packet from married people. It's like a little present. Okay, but we had some money that we were able to come by. So we rewarded the clinicians that were doing very well and the clinicians that were doing well with a very moderate reward. In saying that, Singapore has now begun to a capitated healthcare system, whereas previously it wasn't. So in going forward, we'll be keen to work. We're working currently with our finance teams to see how we can change from a fee-for-service system to a fee-for-quality system. Maybe in a year's time, we'll have more news on that, but we're still at the early stages of seeing how we can do that. Okay, we did make pains, and one of the reasons we were able to get our clinicians on board was that this was non-punitive. So we didn't want the results of the quality results being used to determine people's bonus at the end of the year and things of that nature. Okay, till they had got used to the system. And now it's been in play for the past 8 years. Yes, I think that it's now established enough that we can start using it as a form. One of the things that could be taken into account when the head of department is deciding on the end of year bonus.
Fantastic. Thank you so much to both yourself and Shika. We do have a couple of slides to share with the group who are here joining us today. So my colleague is just bringing those up now. We'll quickly run through these for you guys who have joined us here today. So first up is the conference. This is just a quick and polite reminder to remind you of the conference that will be taking place in Dublin this year on the 29th of September to the 1st of October. There is a QR code on screen now, should you wish to be taken through to the agenda to have a look at that. In addition to the conference, staying on the conference for a moment, a quick reminder that the early bird tickets sales will be ending on the 31st of July. So if for anybody who is wishing to get their tickets at this price, I do encourage you to do this very, very soon, and definitely before the end of the 31st of July. In addition to that, we do have the Patient Scholarship Fund, which we are taking donations for. The Patient Scholarship Fund essentially allows us to bring patients from all over the world to attend our conference and make sure that they are represented. Last year, we were able to bring 32 scholarships into the conference. We were able to raise around $40,000. And it was able to make sure that we actually had a really good representation to be able to share within our community. Following on from this, we do have our implementation directory. This is a map that is featured on our website. The kind of goal of this is to ensure that everybody who is implementing our sets is really represented within our community, and we're able to share that with each other, to share opportunities, to share insights, all of those things. So should you wish to also add yourselves to the implementation directory, it is free. And you simply just have to scan the QR code here to be taken to the page, or you can very easily find it on our website. Or should you ever get stuck, feel free to email any of us. Following on from this, but very similarly, we have our accreditation program, which you can scan the QR code here for to be taken through. Our accreditation program comes in 3 levels and essentially gives you a wonderful badge of honor for demonstrating all of your hard work and dedication to value-based healthcare. Linking it to the implementation directory, you will get a very, very special identifying marker that will show that you're not only just using our sets, but you are accredited by ICHOM ourselves. Following on from that, just summarizing, we want to thank you guys so much for joining us here today. We were covering the hip and knee set predominantly within the presentation from the National University Health System. And if you want to find out anything more about the hip and knee set, have a look at what's featured in this, please feel free to scan the QR code on this slide. This is also on our website, should anybody want to have a look at that. And finally, we are very likely taking a break over the next month, but we would love to welcome you all back in November to join us for a presentation and webinar on cloud-based implementation of the ICHOM CRC set in Victoria. This will be presented by the clinician and Cabrini Health Victoria, Australia. So thank you all so much for joining us. I hope you all have a wonderful day. It's been a pleasure, and thank you so much to our expert speakers, Shika and Dermot. This has been fantastic, and I'm hoping it's helped a lot of people.
Thank you very much, Rihanna. I've included my email address in the chat box there, so if people have additional questions, they can send me emails directly. But thank you again for the opportunity to show what we're doing here in Singapore. Not only are we doing it here, but it's right across the country. And thanks to ICHOM again for hosting this webinar.
And inviting us.
Wonderful. Thank you all so much. It's been a pleasure.